Hello, welcome to another episode of Grand Rounds. And today we're going to be talking about acne. Shanna Miranti from Naples, Florida, and me, Hilary Baldwin from Brooklyn, New York. Our first case is a 16-year-old white male who has acne on both his face and his trunk. As you can see, his face is kind of moderate and his trunk is kind of mild. He's been using over-the-counter stuff, but he's had no success with it. Frankly, he wasn't really using it very regularly. So we see a bunch of papules and comedones on his face. There's no nodules, maybe some superficial scarring, but nothing of consequence. And on his back, he's got some small and medium-sized red papules. So he's only 15. What would you do?
So, you know that I am just as passionate about treating acne as you are, and we could talk about this for hours. But these teen boys are tricky because
Yeah,
even though we think this is a slam dunk case and we are already coming up with a brilliant regimen in our head for these young men, this kid is going to go home and do the least amount of work
right.
possible. So, whatever we
Absolutely.
do and whatever we come up with, we want to hit all four pillars of acne pathogenesis if we can, or at least as many of them as we can. And we want to hit it in the most succinct way. But the truncal acne is tricky because, again, a lot of acne medications have not been studied on the torso. And even though we assume that some have and that they should work, we don't always know that for sure. So, and we don't always know if he'll be able to apply it, to all of those areas.
Exactly.
So, I would definitely want to put this kiddo on a wash. I would definitely want to start him most likely on a topical for his face that hits at least three out of the four pillars of acne pathogenesis. So I would want to start them on the triple clindamycin, adapalene, benzoyl peroxide combination therapy, and then also potentially address the torso because he's not going to want to use a BPO product at least left on overnight, or at least his mother will not want him to, and
Exactly.
stain all the sheets and the towels and everything. So I might consider for him triferritine on the back because we've got some great data on truncal acne on the torso, and we know that it has been studied for truncal acne. So I really like that option for the back for the young men if they can reach it and if he'll apply it.
Well, that's true because mom, can you help me put on my acne on medication on my back? Is something that a teenage boy has said never, right?
Correct.
He's not going to ask for help if he can't reach it or you can't give him a way to apply it. That's not going to happen. Would you consider at the first visit just treating his face and save the trunk for a later day? Because sometimes I do that, especially if it's not summer.
Yeah, that's a great call. I used to only take a look at whatever they showed me. Early in my career, I said, well, if they had it on their torso, I would
Right.
probably, they would come out and they would tell me. I assumed they would tell me. So I always make sure that I look, even if they only complain about acne on the face, mom says, oh no, he only has acne on his face. I always say, let me just take a real quick peek because I
Right.
have been very surprised by
Yes.
horrendous cystic acne on the torso that young man may be hiding from even his parents. So
Yeah.
I always take a look. Certainly if you gain their confidence and gain their trust with a good topical therapy on the face, then they may have more buy-in to want to
Right.
treat their torso later. But I do like to set them off on a great foot and start to get them clearing as soon as
Yeah, I
possible.
agree.
So
I've been surprised actually trying to look at the trunk myself. But data has shown us that 50% of people don't mention that they've got truncal acne. So you really need to look. What happens to me all the time is I say, "Do you have any acne on your trunk?" And the kid says, "No, I don't." And mom says, "Yes, you do." Kid says, "No, I don't." "Yes, you do." Back it is, "Sorry, do I need to be here for this?" Right?
right.
So it turns into an argument that you've created between mom and kid. So yeah, you definitely have to look, even if it's just pulling back the shirt and peering down and seeing what you got.
Absolutely.
So, I did basically what you suggested. I used a triple combo on the face to hit as many of the pillars as I possibly could, with better tolerability, better efficacies than some of our other topicals. But that's going to bleach his shirts and it's going to bleach his pillowcases and his towels, and mom's going to get annoyed. So yeah, I went for something different on the trunk. We were being a little cost conscious on the trunk and went with tretinoin 0.05%, but same kind of idea. Trying to get rid of the zits without bleaching the fabric, without irritating too much. But as you pointed out, having data on the trunk is very important. Acne is not acne is not acne.
Right.
And just because something works on the face doesn't mean it's going to work on the trunk. And with trifarotene, we have data. But we also have data with clascoterone on the trunk. So let's just keep that in mind.
That's a good call. Yeah. I do find that sometimes tretinoin, especially 0.05 or 0.1, even though we think we need to go stronger, we need to go harder. I find generic tretinoin can be very irritating, even to the torso, where we think we'd have, a little bit more hardy skin than our face. So I do like the idea of pulling in clascoterone, which does have some nice data to show that it can prevent even some of the irritation that we can get from topical retinoids.
Yeah. So we saw him back 6 weeks later. He had a little bit of improvement on his face. It's only been 6 weeks, of course, but it had caused some mild irritation, and he had decreased his use of the triple combo on the face to every other day. And he was completely unable to handle the tretinoin on his back, just as you mentioned, and he discontinued it after the very first week. So he was a little bit better on the face. His trunk, of course, was no better because he hadn't used anything.
So at this point, what would you do? What would you do to improve the situation?
You already told me what you would do, and it's exactly what I did, which was to add clascoterone to twice a day to both the face and the trunk, with two ideas in mind. The first is to complete the tetrad of acne pathophysiology on the face, the triple combination plus clascoterone, as far as I'm concerned, winner, winner, chicken dinner, but also to reduce irritation. And I would put it on first and then the other product on top in order to reduce irritation. Because as you mentioned, they have data that shows that it's a moisturizing agent. So very, very helpful combination. And we have truncal data for clascoterone.
I love using products where there's data to back up our
Yes.
decisions and data to back up what we do. And also, it can give us some predictive value to show us what to be able to teach our patients to expect.
Yes.
6 weeks is an early follow-up. I
Yeah.
often will say, I really want to see you back 8 to 12 weeks because I want to see that, that cooking. I want to make sure that we're getting
Yes.
some really great, really fast improvement. But we know with clascoterone, it is going to be slower to work. So we need to
Right.
give it a little bit more time. But I love your comment on layering it first. I recommend the same thing, putting it on
Yeah.
first and then layering a retinoid, which tends to be a lot more irritating on top of it. Great
Perfect.
job.
So let's see what happened at 12 weeks. Returned with improvement in both the face and the trunk. No more irritation, able to use both of these medications on a daily basis and actually improving as a result. So take home message here is moisturize with either a product which has good moisturizing capabilities or with a moisturizer itself first underneath a retinoid or triple combo or whatever it is that you're using in order to improve efficacy by improving adherence to the regimen.
Fantastic. And like you said, you're hitting all 4 pillars of acne
Right.
pathogenesis. So this is a home run. Great job.
Yep, absolutely. So now it's your turn. Hit
Okay.
it.
Well, let me present to you a patient of mine, a 44-year-old Black female with adult onset acne. She was just as equally frustrated with the PIH, the post-inflammatory or perpetual inflammatory
Yes.
hyperpigmentation, because we know it's not just after the acne. We know sometimes that inflammation is all throughout the course of the acne pathogenesis. But she was very, very frustrated with the PIH and the pigmentation left by that acne. Very bothered by her oily skin as well, and was trying a lot of different things to get rid of the oil, to sop up the oil throughout the day. She was taking off makeup, putting it back on throughout the day. So very, very frustrated by a lot of the comorbidities, as we say, with acne that come along with this whole acne cascade and with these hyperproliferative sebaceous glands. She had tried and failed doxycycline, topical unopposed clindamycin, which I certainly didn't recommend that. I didn't prescribe that one, but tretinoin, topical dapsone. And she was not on any birth control at the moment. She had undergone a tubal ligation to prevent pregnancy and didn't really want to, mess with her hormones too much, as she said, and going back on any birth control.
Right.
So, my question to you is with some of these complex cases where we do have an adult female, but who also is really suffering with a lot of the additional problems that come along with acne, what would you do?
Well, the first question I would have is, did she really fail doxycycline? So since she was your patient, I assume she really did. She took it, it was the right amount, she took it for a nice long period of time, and it actually didn't work. She's already on birth control. And at 44, when I see adult female patients with acne, I'm all in isotretinoin land, because when is the acne going to go away? The average adult female acne patient at 25 or 26 is going to go all the way to 45, 47. And to say to an adult female patient, good luck, this is going to go away at menopause is really daunting. And I
Very
think
much
she
so.
needs to be cleared, and she needs to be cleared as fast as we possibly can. She's already got her tubal ligation. It's going to be an easy peasy job. Unless there's a reason not to, I would go there. And of course, it would improve her oily skin too, temporarily, but she'll be happy in the short run.
Well, I
Yes,
would
yeah.
absolutely agree with you. And I did actually have the isotretinoin conversation with her because I agree. I want to put an end to this misery for poor women in their 40s. But she just didn't want to go there because of family history of hypertriglyceridemia, high cholesterol. She was just a little bit nervous to hop on isotretinoin right away. And she had been kind of on and off and not really compliant with any regimen for a while. So I said, look, if you're really serious about, getting your acne under control, I am really serious about helping you and let's go. Let's get this better. I started her on spironolactone, 50 milligrams once a day. I also started her on clascoterone twice daily and the triple combination clindamycin, adapalene, benzoyl peroxide at bedtime. I really also encouraged her to use a sunblock every morning. And we had a good conversation, even though she has, a deeper skin tone. We practice in Southwest Florida, at least I do, and I see a lot of patients that are in the sun. Even if they work indoors, they get a lot of sun exposure and a lot of triggering of their hyperpigmentation. So we had a great conversation about sunblock and about the numerous tinted sunblock options that are now wonderful for skin of color and do match numerous different skin tones. At 6 months, I didn't see her for 6+ months. She came back and she was glowing and not just smiling, but glowing. Her skin looked amazing. She was totally clear. Her PIH was so much better. So she really did buy into the therapy and really was loving the results.
I love spironolactone, especially in this age group, of course, and failing isotretinoin, that's the way I would have gone as well. It's interesting though, both spironolactone and clascoterone, as you mentioned before, take a while to kick in. And so I think the addition of the triple combination, or maybe an oral antibiotic, if she hadn't already been on it, to sort of speed things up a little bit, is essential, if not helpful, because, she's not going to wait around for 3 months to get better. So,
Right.
those two drugs kick in great once they kick in, but it takes a good 3 months for them to really start to get up to speed. So,
For sure.
great
That's why
idea.
it's really important to start them on a topical retinoid that has fast efficacy, so you at least can start to see some improvement. We get their buy-in, we start to see that acne going away, and you can start to see some of the PIH improvement as well. And I love choosing products that have been tested with skin of color patients to know that we can have some great efficacy with that PIH
I
as well.
totally agree. Well, I think that's it for this episode of Grand Rounds. Thank you so much. This was so much fun.
This
See you
was
soon.
wonderful, and it's always so great talking through acne cases with you. I could pick your brain for hours and hours, but
And
we are
are
out of
yours.
time.